Ilaria is a consultant in the Uveitis service at Moorfields and also the pediatric Uveitis service at Great Ormond Street. And I won't take up any more of your time. Ilaria, thank you.
Thank you. So, good evening, everyone. When I was asked to give this presentation about current trends in uveitis, I was considering what was the best angle to prepare this talk. And I felt that there were basically three main topics to discuss tonight. And these are the changes in the diagnostic patterns of uveitis, the advances in multimodal imaging and its role, and treatment strategies. So what we are seeing in specialist clinics here in the UK in recent years is a change in the diagnostic pattern of uveitis. And this is due to a change in disease incidence. So there's been an increase, a rise in tubercular cases and syphilis cases, and this is basically correlated with an increase in tubercular and syphilitic uveitis. As you can see here, syphilis increased up to 15% compared to 21, and the cases of TB in England rose by 10% compared to 2022. And this is obviously reflecting also in our clinic. So this is a 38-year-old Pakistani male who moved to the UK in 2020. 1 year later, he started complaining of right eye visual loss. He was systemically well. He presented to us with these pictures, and we diagnosed a tubercular serpiginous-like choroiditis. This is another 37-year-old Romanian man who moved to the UK in 2012. 10 years later, he started complaining about visual loss in the right eye, together with the weight loss. And again, here we diagnosed a tubercular granuloma. So both these patients, as you see, they are coming from TB endemic area, Pakistan and Romania. But as you can see in this picture, we had a rise in cases of TB even in UK-born population in England. This is a 32-year-old British male who arrived to our attention with this active tubercular multifocal choroiditis. And I've collected for you also a few cases of syphilis that came to our attention in the last 2 months. These are two Caucasian men with a syphilitic retinitis, and this is another guy who showed up a few weeks ago with left eye blurry vision, and we diagnosed this syphilitic posterior placoid chorioretinitis. So we don't have only this re-emergence of old adversaries, but we are also seeing new uveitis entities. So this is a 20-year-old Caucasian guy from Italy. You can see here the picture is basically a panuveitis, vitreitis, inferior snowball. You can see here choroidal involvement on the ICG, CMO. But what he noticed is that together with the floaters and the blurriness that he was reported, also his tattoos were flaring up. So if you look carefully here at Darth Vader's face, you can see that there are some granuloma on the skin, some nodules, and these basically were probably triggered by something in the ink of the tattoo that triggered a localized granulomatous reaction at the level of the skin, but also in the eye. So we are calling this now tattoo-associated uveitis, and we are seeing more cases because of the increased popularity of the tattoo in the recent years. So recent advances in multimodal imaging technique have allowed us to assess in a better way the intraocular inflammation. And these have resulted in a better understanding of the pathogenesis of the disease, and also obviously in a more accurate diagnosis and monitoring of the inflammatory activity and its complication. So what does this new technique or advanced technique in ocular imaging? So the wide field and ultra wide field imaging, including angiography, the fundus autofluorescence, and the OCT, EDI, OCT, and OCT angiography. So back to our 32-year-old British guy with tubercular multifocal choroiditis. So this is a conventional 35-degree retina field, and you can see how that we can basically diagnose an active choroiditis lesion at the level here of the macula. But you can see how you are missing the big pictures without the 200-degree ultra-wide field. And in particular, what you are missing is this inferior active choroiditis lesion and this temporal NBE. So ultra wide field allow for a true evaluation of the real extent of the disease involvement. You can see obviously in the periphery, we are all these MBE, but it can also give information about the activity of the lesion, if the lesion are progressed or if the lesion are not active. For example, in this case, you can see most of the lesion, especially here in the right eye, show early hyperfluorescence and late hyperfluorescence. So this means that these lesions are non-active and they are showing window defect. But what happened in the lesion here indicated by the circle and the arrow? So you can see that these lesions are showing early hypo and late hyper. So these are the active lesions, and the wide-field angiography can help in this. Same for ICG. So you can see early hypo and late hypo, but very dark lesion remaining the same throughout the face and very distinct border. These are the old lesion, while the active lesion, even if they show early hypo and late hypo, you can see that they are less darker, more fuzzy, and with less distinct border. So back to our 38-year-old Pakistani male with tuberculous serpiginous-like choroiditis. How we understand that this disease is active? Thanks to the autofluorescence here. So autofluorescence is a non-invasive technique that allows us to evaluate the activity of the disease. So in this case here, you can see that there is hyper-autofluorescence, meaning that the disease is active. But autofluorescence is also helpful for the monitoring and to understand if our disease is responding to treatment or not. Our patient was started here, this is the baseline, our patient was started on systemic steroid, but you can see, especially in the autofluorescence, that there are new hyper-autofluorescence lesion here. There is basically an active serpentine age, and these indicate activity. So the patient is not responding well. In this case, we decided to put a Ozurdex in, and you can see how beautifully our patient responds to treatment. And we can assess here with the autofluorescence. So there has been a progressive increase in the hypo-autofluorescence, and the healed lesion is here showing hypo-autofluorescence totally. So this is our guy with the tubercular granuloma. We assess the patient, we see this whitish lesion, and how we can understand that this lesion is at the level of the choroid, thanks to multimodal imaging, and in this case, thanks to the EDI OCT. So you can see here that the EDI OCT is showing this homogeneous, hyperreflective lesion at the level of the choroid with secondary retinal involvement. And I've prepared for you these 3 different cases to show how good is the multimodal imaging to help in the differential diagnosis of uveitis. So this is our granuloma with this hyperreflectivity at the level of the choroid, but you can see how this picture and these pictures are totally different. So this first patient, we can see this whitish yellowish lesion, but you can see here on the OCT that we only have inner retinal hyperreflectivity. This lesion resolved without leaving any scurry and without any sequelae on the OCT. So this is a retinal infiltrate in Behçet disease. And you can see how this lesion is totally different from this one. So in this lesion, you can see that we have a full thickness hyperreflectivity at the level of the retina and an increase here in the choroidal thickness. So here we are talking about a retinochoroiditis, and you can see that the result then after the healing is basically retinal atrophy, so totally different from this picture. So in this case, retinochoroiditis, we are talking about a toxoplasmic retinochoroiditis. So you can see how the multimodal imaging is really, really important to understand where is localized the disease and help us in the differential diagnosis. What about ICG? ICG is a relative new technique, and it's really, really important to evaluate choroidal involvement, and especially in distinguish the stromal choroiditis from choriocapillaritis. So on the ICG, we have 2 patterns. So pattern 1 is this one, and is the one of the choriocapillaris. So you can see here there is an area of geographical hypofluorescence that basically correspond to the choriocapillary non-perfusion. And pattern 1 is totally different from pattern 2, which is the one of stromal choroiditis, which is represented by these hypofluorescence dark dots. So let's see some clinical application now. So this is an acute BKH. So clinically, you can see the retinal detachment, exudative retinal detachment that are then confirmed by the FFA with pooling and pinpoint leaking. We have a disc hyperfluorescence. And you can see here how our ICG is extremely useful to assess the choroidal involvement that you could not assess otherwise clinically. So there are multiple diffuse spots to indicate diffuse choroiditis. Another way to assess the choroidal involvement is via the EDI OCT. So you can see here, in this case, EDI OCT is showing in the very early stage of BKH. The choroid is so thick that you are basically not even able to measure it. This is another case of BKH, and it's to stress the importance of the ICG. So you can see here how clinically you can only see involvement in the left eye. So you can see in the left eye this exudative retinal detachment. Same things on the OCT, exudative retinal detachment. But if you see at the right eye here on the optoscolar fundus and on the OCT, everything looks fine. But actually, if you perform an ICG, you can see that even in the right eye, there are some hypofluorescence dots. So to indicate that we are not seeing a disease involving only the left eye, but that there is a subclinical inflammation also in the right eye. So ICG is important for monitoring the choroidal inflammation, but when you don't have an ICG, how you can do? You can use the EDI OCT. So this is an example of BKH monitoring via the EDI OCT. You can see here the progressive reduction in the choroidal thickening. And this is another case of birdshot retinochoroiditis that beautifully showed the decrease in the choroidal thickening with proper treatment. And what about OCTA? OCTA is another non-invasive tool that can be used for monitoring. So this is the type 1, this is a NAMPI, is a choriocapillaritis. So baseline active area of choriocapillary non-perfusion that are shown as hypofluorescence on the ICG. Post-treatment, you can see a resolution of the hypofluorescence, and you can see how on the OCTA, we can see a progressive resolution of the area of capillary hypoperfusion. This is another case of AMPI. Again, you can see how beautifully, with the right treatment, prednisolone, there is a resolution of the area of phloboids at the level of the choriocapillaris. And this is true even for the stromal choroiditis. This is an OCTA in active birdshot. You can see how the area of phloboid here correlate with the hypofluorescence dot on the ICG, and you can see how with proper treatment then the area of phloboid resolved. So let's move now to the last topic, which is treatment of non-infectious uveitis. So steroid, immunosuppressive agent, or both. So as you know, systemic corticosteroid and immunomodulatory agents are the mainstay of treatment for non-infectious uveitis. So systemic corticosteroid, there is nothing new about it, very old medication, is the first line therapy to control the inflammation in the acute phase. We usually start orally up to 1 milligram per kilo. We use them in intermediate, posterior panuveitis, but we also use in acute, severe acute anterior uveitis if they do not respond to topical treatment. In chronic disease, you start at high dose, but you might need to maintain then a low dose of systemic steroid to achieve a control of disease. When we move to systemic immunosuppressive agent, or where we add an immunosuppressive agent. So in case of very severe disease, we start steroid and then we start also the immunosuppressive agent. In case of lack of control with the corticosteroid, or if tapering down the steroid or after stopping the steroid, there is a recurrence of the disease. Obviously, we also need to keep in consideration the side effect and the possible adverse event associated with corticosteroids. So in some patients, we just need to start systemic immunosuppression because they are not able to tolerate steroid. So which are the agents that we use? Antimetabolites, methotrexate and mycophenolate, These are the most commonly used. T-cell inhibitors like cyclosporine and tacrolimus, we usually use them when we want to achieve control quickly. Cyclophosphamide, now not very used because of the side effect. So you have to keep in mind that this medication takes several weeks to kick in, at least 8 weeks. So basically you have to maintain patient on a low dose of systemic corticosteroid until the immunosuppressive agent take effect, and then you can try to stop your steroid. Methotrexate, usually therapeutic dose is 10 milligram per meter square. You can give subcutaneously or tablets. Mycophenolate, full dose for an adult, is usually 1 gram twice a day. Obviously, you have to monitor kidney and liver fraction and full blood count, usually every 12 weeks. Which is better, methotrexate or mycophenolate? Well, there is not real difference. This is a randomized clinical trial, 200 patients, and basically you can see here how the mycophenolate was not more effective than methotrexate. So same level of efficacy. When we move to biologic, so before moving to biologic, you always have to maximize your dose of immunosuppressive agent. We move to biologic when the conventional immunosuppressive agent fail or where they are not well tolerated by the patient. The adalimumab anti-TNF alpha is the first FDA-approved biologic for the treatment of non-infectious uveitis, intermediate, posterior, or panuveitis. Keep in consideration, is not approved for anterior uveitis, so only for uveitis at the back of the eye. It's a subcutaneous injection every 2 weeks, and we give the adalimumab together with the mycophenolate or methotrexate. So it's not a monotherapy. Why? We use methotrexate or mycophenolate because we want to reduce the probability, the likelihood of formation of antibodies against the drug, and we want to promote a higher level of the drug in the blood. So this is a birdshot, 32-year-old lady. You can see here baseline active vasculitis on the FFA, active stromal choroiditis on the ICG. We start her on mycophenolate, full dose, 1 gram twice a day. We repeat angiography after 6 months, same level of vascular leakage, same level of choroiditis. So the patient was not really responded well. So we decided to escalate treatment to adalimumab. Again, 6 months after, on mycophenolate, full dose, and adalimumab, we repeated the angiography, resolution of the vasculitis, and resolution of also the active choroiditis. But what happened when even the adalimumab is failing? So this is a protocol that we are using at Goshen that's been approved by the DTC. This has been approved for JIA, anterior uveitis, a chronic idiopathic anterior uveitis, but basically we are doing the same at Moorfields. So patient on adalimumab every 2 weeks who fail, we check the level of the drug in the blood and we check the presence of antibodies. For patients who have no antibodies or very low level of antibodies and low level of the drug below 5, we go to weekly. So instead of giving 2 weeks, we give weekly. If obviously they have already a very high level of the drug, there is no point in going to weekly, or if they have a very high level of antibodies neutralizing the drug, there is no point in going to weekly. So we switch biologic. And where we go? We usually go to infliximab or TOC. Infliximab is another anti-TNF alpha, is delivered with an infusion, while TOC can be delivered by infusion or subcutaneous injection, is interleukin-6, usually work really, really well for cystoid macular edema, not really well for anterior uveitis. What about localized treatment? So when we are deciding about which treatment to use, we have to take in consideration different aspects: laterality of disease, severity of the disease, but also some patient factors, general health of the patient, any contraindication to use of steroid, any possible side effects. So localized treatment is usually used in unilateral disease, asymmetric disease, if the eye is the only reason for the treatment, so there is no systemic disease, and obviously in case of contraindication or intolerance to systemic therapy or resistance to systemic therapy. Keep in mind that local treatment is only useful in some kind of uveitis entities and some kind of clinical features like CMO vitritis, useful in intermediate or retinal vasculitis. Less useful, we will see in choroidal inflammation. So which are the implants that we are using? So we have the DEXA implant, which is licensed for active disease and usually lasts for 3-4 months. We have then the fluocinolone implant. The fluocinolone is only approved for prevention of disease relapses, so it's not approved for active disease. So we usually inject after we achieve control with the DEXA implant, and if we have achieved a good control of the inflammation with the DEXA implant. There is no guarantee that if you inject the fluocinolone implant, it will respond equally to the DEXA implant, but we have also a class that we call partially responder, in which the fluocinolone implant can reduce the number of Ozurdex injections. Just a few cases to conclude. This is another bird shot. You can see baseline active vasculitis, active choroiditis. Patient was, we started on steroid and microphenolate 1 gram twice a day. You see how the stromal choroiditis totally resolved, vasculitis in the left eye totally resolved, but right eye still active vascular leakage. So we have a case of resistance to systemic therapy by the vasculitis in the right eye, and to reduce the systemic treatment burden, instead of escalating to biologic, since it was only basically the disease in the right eye and was a retinal vasculitis, we decided to inject the first Ozurdex. She responded really well, but obviously recur again after 3 months. So we decided to inject another Ozurdex and then an Iluvien, and you can see how we achieve quiescence. Iluvien not working really well in choroidal inflammation. So this is a paper we published a couple of years ago, again bird shot. So this is 12 months after Iluvien. You can see resolution of the vasculitis, but still active choroiditis and very thick choroid on the EDI. And this is another case, 3 months after Iluvien, resolution of the CMO, but still active choroidal involvement. So it's good in macular edema, retinal vasculitis, not really effective in choroidal inflammation. Last case to conclude, this is a case of PIC. You can see here active inflammatory lesion on the OCT and active CMV. So in this case, we start oral steroid and we decide to taper to stop and to inject with anti-VEGF. However, a few months after stopping steroid, again here, new PIC lesion. You can see here also on the autofluorescence. So we decide to restart steroid and to keep a low maintenance of 5 milligrams a day. But again, a few months after, new PIC lesion, and again, reactivation of the CNV. So we decided to inject again with anti-VEGF, increase the steroid, and start a second-line immunosuppressive agent. But you see how here, 6 months after starting microphenolate full dose 1 gram twice a day, again, new lesion very close to the fovea. So at this point, we are dealing with one eye disease, right eye only. We are dealing with PIC, which is only confined to the eye, so no systemic association. And we are dealing with a case of resistance to systemic therapy. So we decide to stop everything, inject an Ozurdex followed by Iluvien, and this is our eye, March 2024, inactive for 2 years. To conclude, you all know very well the potential side effect of the implant, which are raising intraocular pressure and cataract. However, we are seeing also new complications. These are 3 cases that developed CMV retinitis after the injection of the Iluvien, and this was due to severe localized immunosuppression. Thank you for your attention.